Cool. And we're recording. All right. So welcome. This is EMS Medicine Live for May 2016. We hope you had a good Memorial Day weekend. And as everyone else has said, thanks to our vets for what they did and they're doing now. And hope it was a good day for everyone. This is EMS Medicine Live. Obviously, the goal is twofold. We want to involve both community and academic EMS physicians to both share information and knowledge and lessons learned from our experiences. And I like using the live format, trying to bring in folks for live participation if they have any comments or things to add to the conversation. We do use Zoom, which you're hopefully on now. We have muted everyone so they don't add to background noise while Darren's speaking. If you have questions, you can chat them to EMS Medicine Live. That's my laptop next to me, and we'll try to answer questions either at the end or we'll break in and ask questions. You can try raising your hand virtually. No one's done that in the past year and a half, so try to be the first if you want to. This is being recorded. This will be posted on our typical YouTube and Facebook sites for watching later. If you want to record in your end, you feel free to do so. If you want to find us, just Google EMS Medicine Live. We're the first 3 or 4 hits all the way across the board for Facebook, YouTube, and our websites. And questions at the end, we'll try to unmute everyone. If anyone has any questions, it'll be a good time to ask. So today we have Darren Braude from New Mexico talking. Did his undergraduate at Colgate University, which is a stone's throw from here. I haven't gone to Hamilton College myself. I know Colgate's in Hamilton and Hamilton's not in Hamilton. Very confusing for some of us.
Go figure.
But good place. Went to med school in New York and did his residency in the other coast in UCSF. And now is in the middle of the country in New Mexico where he works. And I will turn it over to him.
All right. Well, thanks, Chris. I am getting a little bit of background noise. I don't know if anybody else is hearing that.
Let me check real quick. Nope. Oh, Keeperman. There you go.
Okay. Better. All right. Well, I appreciate the opportunity to be here. Honored to have the invitation and get a chance to talk about one of my favorite topics, extraglottic airways. The title is Updates and Controversies. We'll probably spend more time on controversies than we will on updates, given the sophisticated audience that's with us today. See if it, okay. Conflicts of interest, no financial conflicts of interest to disclose relevant to any of the devices that will be discussed today. If I have a conflict, it's just that I'm probably on one end of the bell curve regarding extraglottic devices, and just being a real early adopter and really a fan and try to push the envelope. I think we all need to recognize where we are on the bell curve with everything that we do, and I need to, admit and acknowledge that I am on sort of the leading and bleeding edge at times, and I think we need folks on all ends of the spectrum with everything we do to have a good dialogue and keep things moving forward, but we need people on the other end to keep those of us that are trying to move some things forward from maybe moving them too far forward. So that would be my conflict.
Try again.
Going slow. All right. So a little history of extraglottic devices, just as a reminder. These go back quite a ways. I put this slide up to recognize that this is my 30th year or 31st year in EMS, but there are some folks, including some of our residents and fellows, that don't remember devices like the infamous, probably better to call it infamous than beloved, EOA and EGTA Airways. These were really some of the first devices that were intended to be placed blindly and intended to be placed somewhere other than through the vocal cords. Now, this particular device, however, had quite a few limitations. Those who have used it remember you still had to create a great mask seal. It did, however, create a wonderful conduit to direct vomit at anybody who you were pissed at on any particular day. But this device really led the way, and we now have, you know, a variety of devices. We should separate them into the categories of supraglottic and retroglottic. Across the industry, people tend to just use the term supraglottic, but that's really not accurate. There are the devices that are indeed sitting above the glottis, but there are a lot of devices in use, perhaps the predominant number of devices for EMS that are actually retroglottic devices that are sitting in the proximal esophagus, but distal behind the airway, retroglottic, as you can see in those pictures. But none of these devices that we're talking about today go through the vocal cords. There are, if we look at the supraglottics, I mean, it's amazing the number of devices that are available and on the market now. We've been discovered as an industry. People are now designing and marketing devices just for emergency use, instead of us just sort of adopting devices that were really intended for the operating room setting. And so that is really an exciting development. This is by no means all the devices that are on the market. This is just a few of the supraglottic devices. One of the things that's particularly exciting now is how many of these devices, all of the ones pictured that allow for gastric venting and or gastric decompression through dedicated channels. There's different ways that they approach this, and some it's across the board in adult and pediatric sizes, some it's only in adult sizes, but the ability to decompress the stomach is, I think, a real advantage. I didn't discuss it as a controversy today, but there are folks that feel like putting, and this is kind of more on the anesthesia side, that if we put something through the lower esophageal sphincter, now we're opening that up and we're actually predisposing ourselves to problems. I'm on the side that doesn't believe that in most of our patients that's a completely patent sphincter anyway, and that decompressing the stomach is a big advantage. The AirQ, Dr. Cook, they've taken the approach, for example, of potentially suctioning above the lower esophageal sphincter in the distal esophagus, but not going through it, and instrumenting that. So different approaches. This is a bunch of devices. We were a heavy LMA Supreme system. We're now a heavy or a gain system. And the real reason that we switched was not because of failures with the Supreme, and we're seeing more iGel penetration in our market as well now. If you look at the retroglottic devices, everybody in EMS is familiar with the King Airway, or the laryngeal tube as it's known in the rest of the world, and is familiar with the combi tube, which arguably is the predecessor. Used it for many, many years, still think it's a reasonable device, but it has some technical issues and doesn't have pediatric sizes. Interestingly, the Easy Tube is now available as an alternative dual lumen airway. Not many people in this in the United States, to my knowledge, are using that. But I'd really like to move the discussion into the next slide, if it would let me.
I got a problem with some of the callers. 1 second, I'm sorry. All right, there you go.
Okay, so talk just briefly about something coming. There's probably lots of devices coming that we don't even know about. One that we certainly do know about is the intubating King Airway, the ILTSD, which is available in Europe, and we hope to see that in the United States soon. The King Airway is first prioritizing, let me go back here. They're first prioritizing the release of their full pediatric size range of devices, and then we should see the intubating device. For us, one of the biggest issues we have with the King Airway right now is the inability to easily intubate through it. And that's one of the reasons that we've been particularly happy using devices in the field that allow us in the emergency department to seamlessly transition through the device with continuous ventilation to an ET tube. And so the new King Airway will add to the devices that allow you to do that. All right. The slide set doesn't want me to go back. It wants me to be right here, which is good. And we're going to talk about these controversies, and we can certainly talk about others as well with discussion today. So first discussion is these devices, who should be using them, at what level of training, at what scope of practice do they belong? And that, of course, really depends on who you ask and the region that you're in. The reason that I bring this up is that in our jurisdiction, we're a little more progressive with these devices than we've seen in some places. If you look at the sort of the standard algorithm, the extraglottic airways will appear at the advanced EMT level in most cases, sometimes specifying the old multi-lumen airway, sometimes specifying supraglottic devices. Rarely is the term extraglottic get used in scopes of practice, unfortunately. And ALS, it's sort of, assume that you're able to do everything at the AEMT level and above. I think that from my perspective, if you look at the expansion of these devices to the BLS level, and potentially in New Mexico, the first responder level, the thought is, critical airway skill, and that extraglottic airway insertion is frankly easier than bag mask ventilation in many patients. We all know that. Bag mask ventilation is notoriously difficult, yet we ask our least experienced and least trained providers to be doing that routinely, and giving them potentially a better tool to facilitate that is a good idea, especially if you consider the fact that a lot of this is happening in rural areas where you can't expect somebody to provide effective bag mask ventilation by themselves for a few minutes, let alone for 30 minutes, an hour, 2 hours. Just not reasonable. On the flip side, the debate that often focuses on, is it reasonable? It's not that we can't train the providers at these levels to do this, but it's just already packed full. We can't get our volunteers to go through the training as it is. One more thing to add to the length of training is unreasonable. And that's what I hear. There's also folks that consider that extraglottics are just too advanced for somebody at perhaps a basic level. I personally don't believe that's the case. But we should say, I'm one of those people that is responsible for selling a bill of goods that over the years we've told people that these are brainless devices. These are mindless devices. Anybody can do this. A monkey can do this. And that's not really fair. These devices do require some thought and some evaluation skills, and we have to incorporate that into our training. So in New Mexico, we do approve these devices at the BLS level. We did have them at the first responder level as well. We also, interestingly, recently approved basic EMTs and above to decompress the stomach as long as they're going through an FDA-approved device with a channel that's designed to facilitate that. So a basic EMT is certainly not allowed to walk up and pass a gastric tube through somebody's nose or mouth, but if you have a device with the channel, they can decompress the stomach. And that's a huge advantage if you have a patient who's been bagged for a while and has a full stomach to be able to do that. Or in an urban area, and we have lots of people on scene, but we don't have a lot of medics potentially, being able to delegate those tasks out. So out in the Wild West, we're expanding that scope. Some of you listening, that may be exactly what you are doing and have been doing for a long time, but some of you, that may be a new thought. So that'll be controversy 1, and we can see if anybody has questions about that. Otherwise, I want to move into controversy 2, and as we move along, there'll probably be more and more topics for debate. So aspiration protection. I think this is probably what I hear the most from folks when they're sort of describing why they don't use the devices more. It's concern about aspiration. And I'll go so far as to call it a myth that the cuffed endotracheal tube prevents aspiration and the extraglottic airways do nothing to prevent aspiration. We certainly see aspiration with endotracheal tubes, and the extraglottic airways, frankly, do way more to prevent aspiration than most people think. I will not disagree that the cuffed endotracheal tube is the best that we have and should remain the gold standard without question. Where I see this, though, in the real world is that most of our patients where we're worried about this have already aspirated, and people spend a tremendous amount of time and effort trying to prevent a complication that has actually already occurred. The second thing to consider is that the intubation itself is more likely to cause an aspiration event than placing an extraglottic airway or extraglottic device, depending on the abbreviation you want to use. And then what I said before, many of these devices offer more protection than people realize, especially going back to the beginning, if you're able to decompress the stomach through the device. We're not going to get out the big chunks, but if we can get out a lot of the air and fluid that's creating that pressure, that really makes a huge difference. But these devices, whether you're talking about a retroglottic device that has a cuff sealed in the esophagus, or whether you're talking about a supraglottic device where the device itself is, you've got your esophagus and it's sort of fitting in there and then sealing over the glottic opening, there is definitely aspiration protection included in that. I wish we had better studies to look at this, and we certainly have OR studies, but it just doesn't reflect our population. But this is an interesting one that I found that a lot of people are not aware of. It's a 2008 cadaver study. So the fact that it was 2008, there's some devices here that are not necessarily the ones being used the most in EMS, but a lot of them are. We do have the combi tube included here. We have the laryngeal tube included here, and that's really important. I wish we had things like the Oragain and the LMA Supreme, for example. But what's interesting is how much, when they basically built up a pressure column, how much pressure these devices could protect against. It's quite remarkable. And you can see that some of these devices were able to block the esophagus up to about 80 centimeters of pressure. And even the old classic LMA, which we've really moved completely away from in our system for EMS, believing that there are better devices, although I can't tell you there's evidence for that. Even that classic LMA had a remarkable ability to protect. So we've looked at this a little bit in our own system, and this is just some kind of QA data. But we looked at 94 patients that got intubated and compared them to 67 patients that got an extraglottic airway. And then we looked at aspiration data up to 48 hours in the hospital. And if you just look at the raw numbers, 15%, 19%, it would look to be a little bit higher with the extraglottic. But what's interesting is in the charts, we had a remarkable number of patients that had blood and emesis in the airway, which basically assures that aspiration has or will occur. And that was more common in the extraglottic group. That sort of makes some sense, because a lot of that's why intubation may have been difficult, and the providers either failed at intubation or just opted to go to an extraglottic device. And if you exclude those patients, then the aspiration rates actually go in favor of, probably not statistically significant, but probably go in favor of the extraglottic devices. A lot of this is aspiration that has likely occurred before we got to the patient. So in our system, just looking at a little QA data, we certainly did not see some increase in aspiration risk with these devices. And a lot of these are patients that had attempts at intubation and then got the extraglottic. So they're even at higher risk. So for me, I think it comes down to endotracheal intubation comes with some potential serious complications, and trying to get the perfect airway device in, if that comes at the risk of other complications, then there's a real risk benefit, like everything in medicine, that we have to consider. And there's never one answer, and every system has to make a decision, and every provider in a given case has to make a decision based on what they have available in their scope of practice and what the situation is for that patient. But I do think that sometimes that concern about aspiration that, again, may have already occurred or may still be prevented with an extraglottic device drives people towards intubation and potentially, in some cases, more complications. So that would be controversy 2. Do these devices provide aspiration protection? Controversy number 3 is the cerebral perfusion pressure issue that a lot of folks are probably very familiar with. And what do we know? We know that if you want to kill a pig, this is a good way to do it. So if you're planning a barbecue and you're looking to euthanize the pig, you actually could just, maybe use one of these devices. But seriously, this comes out of a very well done study from colleagues of ours that looked at cerebral blood flow issues in a swine model of cardiac arrest, and really, really well done study. And what they were looking at cerebral blood flow. They actually put catheters in to measure that flow, induce cardiac arrest with several different devices in place. And they did show that there was, compared to endotracheal intubation, decreased carotid blood flow. And they were, certainly did not try to oversell or overstate this, that this was sort of a concept paper to decide, should we be looking at this? And they did find there was absolutely concern and that we should investigate this more. And if you look at some of the papers, this is not from their paper, but this is another paper that sort of looks at the anatomy and where these devices sit. There's reason to think that the situation in humans could be different than the situation in the pigs. So what we did here is a convenience sample. This is interesting for a lot of folks. We have a lot of patients in our system come in, as you'll see in some data later, come in with extraglottic airways. We place extraglottic airways in the emergency department. In fact, just this weekend, I was called over to an airway in the pediatric emergency department for some assistance. And when I got there, the patient had an extraglottic airway. It was in place. They had not made any attempts at intubation. They had just placed it to facilitate oxygenation. And we were just having a calm conversation. Respiratory, didn't think twice about it. That's just our practice pattern. And so when these devices come in, we don't routinely, if they're functioning, we don't routinely remove them right away. We will do our initial resuscitation. We sometimes send patients to the CT scanner. We sometimes send patients upstairs with these devices in place, again, if they're working very well. So we actually had a convenience sample a few years ago of 17 patients that had CT scans of the neck. Lots more patients had CTs of the head. But this was 17 patients that went to the CT scanner with one of our extraglottic devices in place, which allowed us to actually look at the images to see if a neuroradiologist could find any evidence of compression of the cerebral vessels. And we were not able to identify any evidence of compression, with the clear limitation. One, this is 17 patients, this isn't 1,700. And these are not patients in cardiac arrest or in a low flow state, or they wouldn't have been going to the CT scanner. And so that we have to factor in. There's always limitations. But here are some images. And when you look, the arrows are pointing to the cerebral vessels. This is a patient with an LMA Supreme. This is a patient with a King. This is a patient with a combi tube. And you look at where these vessels actually sit compared to where they sit in the swine model, you can see that they're it's reasonable to believe that there might not be any mechanical effect on these. On the flip side, low flow state, maybe it's different. But that certainly made us feel better about continuing to use these devices until we have more data. So that was sort of our thought process for right now on these devices in a human model is it's reasonable based on the anatomy until we have more information. But we'll discuss some of that other data here in the next few minutes. So without any questions, I'll just keep going and we'll talk about controversy number 4, which is, should these devices be primary or secondary devices in out-of-hospital cardiac arrest? And that really ties in to the last 2 discussions that we had. So arguments in favor of doing this as a primary airway, higher first pass success and faster than intubation. And that's especially true if CPR is in progress, as it should be, if the person who would be doing the intubation is not a frequent intubator, and certainly if the positioning, if you're, as we all know, the cardiac arrests in the field are not always run in spacious conditions. that can factor in as well. They do allow CPR to continue. Not to say you can't do intubation with CPR in progress, but that is something that a lot of people are not as comfortable with. Recognizing that first pass, and I'll come back to this a little bit, but it really is important that we get these patients managed on the first pass. And if we consider the fact that in a lot of our cardiac arrest patients, aspiration has already occurred, maybe that shouldn't be our primary concern in terms of prevention, and we need to focus on some other things. We're always thinking about it, and more aspiration is worse than less aspiration, but maybe not the primary concern. Now, if you look at it, saving it as a secondary device, the arguments would be, we know the endotracheal tube is the gold standard for airway management. We have this lingering concern about cerebral perfusion pressures that we think we've addressed to some extent, but not completely in the cardiac arrest model. And then, and I'll come back to this at the end, the less you intubate, the lower your success rates will be. That's the self-fulfilling prophecy. There is less aspiration protection. I can't tell you that that's not the case. And then there's this question of outcomes, and that's what's, I think, what really, really matters. So in our system here, we continue to encourage the use of extraglottic devices, and the vast majority of out-of-hospital cases are managed. And this slide actually should be updated. It was LMA Supremes, and it is now the Aura Gain. We allow one attempt at intubation with CPR in progress, but we have a lot of, and I'll show you the data at the end, we've really moved, the crews self-selected to use extraglottics in the vast majority of cases. Our first pass success when we looked at this with the LMA Supreme was 87%, and that was early on in our use of the Supreme. That was sort of our quality assurance numbers when we first adopted it, and it was 96% within 2 passes. And I'm very confident that if we looked at the last 6 months that we were using the LMA Supreme, the numbers would be even better than that. And in our system, we are not close to achieving those kind of numbers with intubation. So a little bit of background that has to factor in to this discussion. The first pass, the importance of first pass, intubation success rates, and outcomes. So here are a couple studies that I refer to frequently. These are not out-of-hospital studies. They're not cardiac arrest studies. But it's interesting that even in the hospital, in non-arrested patients, the incidence of complications just goes way up with multiple attempts. And we've seen that in both in the anesthesia emergency airway setting as well as in the emergency department setting, dramatic increases. And so we have to assume that in a cardiac arrest patient, until we know otherwise, that they're probably suffering from multiple attempts as well. Now, you could argue if one of the potential complications is cardiac arrest, well, they've already got that. Bradycardia, maybe they already have that. But multiple attempts probably is not good for these very fragile patients. Begs the question, though, does this matter in out-of-hospital cardiac arrest? If they're continuing CPR, we'll just assume that. I can't give you that data. Intubation success rates, however, every system is different, but a couple publications from our colleagues certainly show that in this Henry Wang study for 1,272 cardiac arrests, cumulative success rates, the first attempt success rate, 70%. Okay, and even with 3 attempts, got still were hovering in the 90% range. So 70%, if first pass matters, not wonderful. And then in Mike Hubble et al. PEC meta-analysis, we again see numbers cardiac arrest with multiple attempts overall did pretty good, but to get there, there was multiple attempts, and that's a problem. But I think what probably matters the most to everybody is outcome. That's what we should really be focused on. And we have a number of studies, many from our EMS physician colleagues that have looked at this in a variety of ways. And a lot of this has come out of Japan. They have very nice registries, and a lot of you will be familiar with this data. Now, in this was a study that had 16,000 patients getting endotracheal intubation, 34,000 patients getting LMAs. These are just huge numbers. The overall rate of neurologically favorable 1-month survival was unfortunately very, very poor in this system at 1%, but the rates of the outcomes were, you'll see 1.14 in the endotracheal group, 0.98% in the LMA group, 1.04 in the EOA group. Very, very close and dismal all the way across. Another study out of Japan, 7,500 out-of-hospital cardiac arrests. They had 1,679 intubations, almost 3,700 supraglottic airway devices. Favorable neurological outcome was similar between those two groups. These were a little bit better numbers at 3.6%. In this study was interesting. Early placement of an advanced airway was significantly associated with better neurological outcome, which is not a consistent finding across the board at all. But I think we've seen that in other things. For example, in some of our epinephrine data, epinephrine worsens outcomes, unless maybe it's given very early. So it'd be a little bit interesting to get better data from other populations on the time frame of this. Another Henry Wang paper, and this is from Rock, and some of you all may have contributed to this, endotracheal intubation versus supraglottic airway insertion. They had 10,000 plus cardiac arrests, the vast majority intubated, but they still had almost 21% with extraglottic devices, and they found survival to hospital discharge with satisfactory functional survival was a little bit higher in the endotracheal intubation group than the supraglottic group. The problem that they had, and that the problem that a lot of these studies have, is whether or not we can control for the patients who got intubation on first attempt right out of the box, and compared with patients who got an extraglottic device first attempt right out of the box, as compared with the patients who got a supraglottic device after 1 or 2 failed attempts at intubation. And most of the time in these database studies, they haven't been able to control for that, and it's based upon the final airway that shows up in the patient at the hospital. And that's unfortunately a huge limitation to be able to look at this data. Same issue here with Jason's study from the CARES registry. And they said, they found survival was higher among out-of-hospital cardiac arrest patients receiving intubation than a supraglottic device. However, and again, if you look at these numbers, these aren't huge differences between the groups, but they very specifically were not able to control for that factor that I just mentioned. But what they found, and this is also a recurring theme, that patients who got no advanced airway did the best. So that we see time and time again. So this is another Cincinnati-based study with a bunch of airway colleagues. This is endotracheal intubation versus supraglottic airway placement, a meta-analysis. Patients with out-of-hospital, so their conclusion from 10 studies, patients with out-of-hospital cardiac arrest who receive intubation are more likely to obtain ROSC, survive to hospital admission, and survive intact compared to supraglottic devices. And that seems to be a particularly damning statement for those of us using extraglottic devices. However, they do say here, this is right out of the paper, given that all 10 articles were observational cohort studies, overall quality was considered low or very low. I think that we really have to take this with a grain or a shaker of salt. If you're doing a meta-analysis and all you have are poor studies, then you can't really bank on the results that you get. And again, if a lot of the studies going into this were not able to separate out patients first attempt intubation, first attempt extraglottic versus first attempt intubation and fourth attempt extraglottic, we don't really have our answer yet. And a lot of these folks are working on this right now, and they're trying to answer this question. I believe the ROC group is working on that question right now, and we're all anxiously awaiting their answer. But the elephant in the room here really is this whole question of advanced life support and whether any of these devices are helping our patients. I think I didn't include it, but I think you're all aware of the very recent Medicare data-based study that came out saying that BLS was better than ALS. And this is going back, this is to the Ottawa, studies in Ontario, studies from Ian Steele that found advanced life support, didn't make a difference in survival. And how much of that is an airway issue, I don't know. This is a study that again showed patients who got bag mask ventilation did better than patients who got intubated. And this is a recurring theme. We've seen this in studies we just talked about. This is a study that had, just a mere 650,000 out of hospital, cardiac arrest patients. Both endotracheal intubation and the use of supraglottic devices were similarly associated with decreased odds of neurologically favorable survival. So this is probably the bigger question we should be asking ourselves, is not which device, but whether a device, and why are we seeing this? Is this a factor of interruptions in resuscitation in general, or CPR specifically, and compression fractions? Is this a biased sample? Is this very likely that the patients that didn't require an invasive device were the ones that had VFib, got shocked right away, they converted to a perfusing rhythm, were waking up, nobody ever put in a device? That's a huge bias that we have to be able to separate out before we can really answer this question. But the other piece that's interesting to me that I don't think we have, evaluated is this whole issue is the problem that we talked about at the very beginning. Bag mask ventilation is hard. And maybe, ironically, that's a good thing. And maybe these devices are just allowing us to overventilate our patients, and we know that overventilation is bad. So that would be, another interesting way to look at this question. This is brand new data that looked at the compression fraction during out of hospital cardiac arrest resuscitation between devices, and after adjusting for potential confounders, they found a slight increase. It says pre and post airway compression fractions were higher for SGA than intubation, and we're looking at numbers that were 73% versus 70% pre and post, 77 versus 72.5. So not big differences. Hard to know if those differences have real clinical implications. But arguably, if you look at the difference in the studies that tried to look at neurological outcome with these devices, we're not looking at much bigger differences. But this suggests to me that it might not be this issue of interruption of resuscitation for the placement of these devices. That may be something that we're seeing here, but maybe not enough to account for the findings. And I think this is a really, really fascinating question. So when we look at this, we have to ask, is it positive pressure ventilation? Are we killing our patients with ventilation? This is, one of my soapbox issues. Every time I'm in the field on a cardiac arrest, I feel like this is one of my, big issues that I'm whispering in somebody's ear, just, slow down, just slow the ventilation down. We're great about using the metronome for CPR, but I don't think we're paying attention to flashing lights and things on ventilation. We're familiar with the cardiocerebral resuscitation work that Will Braude and colleagues have done. And we've done this in our system for years since these studies came out. Standard practice, initial cardiac arrest resuscitation, non-rebreather, let's avoid positive pressure ventilation. So what's my opinion on all this? I don't think we have the answer yet. It is possible that the extraglottic devices have a small negative impact on cerebral circulation in low flow states, and maybe that's enough to see a difference. I'm not convinced of it yet. Multiple attempts at intubation or interruption of CPR, I think are worse than that whatever small effect the extraglottic device has. I can't give you good data to support that comparison. If you're able to reliably intubate a patient rapidly on first attempt without interrupting CPR, then that's probably the best thing for the patient. In every other circumstance, then I would think that an extraglottic device is equal to or potentially even better than intubation. And I really think that the real issue here may be that positive pressure kills, and not being able to achieve a good mask seal bagging a patient may ironically be to their advantage. So I'll offer one possible solution to this, which is the use of the ventilator during cardiac arrest resuscitation. And in one of my services, we've been doing this for a while, or at least encouraging providers to do this. And I'm hoping to have enough numbers to have a case series. But we use that vent right there during cardiac arrest, whether we're doing mask ventilation or an LMA type device, supraglottic device, or endotracheal intubation. You just basically, there's a few tricks with the alarms and what you have to do to be able to do this. Of course, we're doing asynchronous ventilation and compressions when you're doing that. But we do, during the arrest, we're doing 8 in an adult patient, 8 ventilations a minute, and a very simple system. If you're using an LMA3, or the patient would take an LMA3 if they had one, they get 300 tidal volume, a number 4, 400, a number 5, 500. And then if we get ROSC, we just increase the rate from 8 to 16 in our adult population. And anecdotally, we don't have a lot of people walking out of the hospital neurologically intact, but some of those recent saves have been in patients that got ventilation via the vent during cardiac arrest. So it certainly anecdotally doesn't seem to be killing patients, and it'd be very interesting to see if that's helping. So I would just offer that up. If ventilation is really killing our patients, then maybe this is one thing we can do. If there are other folks out there listening who are managing cardiac arrest specifically with a transport ventilator, I'm not talking about after return of circulation, I'm talking about while chest compressions are in place, please let me know that offline. I would love to compare protocols and see what our outcomes are. All right, so move quickly through the rapid sequence airway discussion just to touch on controversy number 5. So RSA is a concept that we developed here in New Mexico, which is, the idea here is that we combine the pharmacology and preparation of RSI, but going immediately to the planned placement of an extraglottic device. So this is not, I meant to do intubation, but the patient desaturated, I couldn't bag them up, so I ended up putting in an extraglottic device before I ever had a chance to intubate and do laryngoscopy. Totally appropriate management, but that's not RSA. RSA is, this was the plan from the outset. We like to use a device that allows gastric decompression and like to use a device that allows intubation through the device. This evolved on the flight crew side, and if people are interested in how we came to this, I can discuss that offline with folks. We initially published our first case report on this back in 2007. We probably started the concept 2005, 2006. We have found it fast. We found high success rates, minimal airway trauma, and love the combination of putting in a device that allows for intubation to, then not have to, be able to continue ventilation from that point on, even when you change out the tube. Disadvantages, Now, this is not cardiac arrest. This is, presumably a perfusing patient. This does not provide a definitive airway. And there are some patients that are just not good extraglottic device candidates. So you'd have to, be very cautious going into any of these cases with an RSA strategy. And I would, advise against going into these kind of patients with that as a strategy. I still use extraglottics as backup devices in these kind of situations, absolutely, but I wouldn't use an RSA as a first line plan. This is something we use in the pre-hospital setting, but I also use it in the hospital setting as a pre-oxygenation strategy in some cases. And we've published on this in a few settings. This was a really interesting case just because this patient went from pre-hospital ground, got RSA, ground to a level 3 trauma center, or flown to a level 3 trauma center, but the device was RSA by a ground service, transferred to a flight service, flown to a level 3 trauma center in a long, big rural area that we're in, evaluated at that trauma center with the device left in place. Second flight team called to transport the patient to a level 1 center, evaluated in the emergency department of a level 1 center, not by me, and transferred up to the ICU and then to the OR the next day, all with that initial LMA Supreme in place. This is, so our colleagues up in Twin Cities, RJ Frasconi in particular, have been looking at this approach as well. They just don't call it RSA. They just call it usually RSI with another device. Same concept. And they've looked at this a couple times. We've published on using this in the emergency department for pre-oxygenation. And some other folks have as well. And they just called it pre-oxygenation with the LMA in critical care. They didn't call it RSA specifically. And we are right now working on a case series of, we'll see how many patients we come up with, somewhere in the 40 to 50, where we have some data to share with people. So as a summary, that's a whole topic in and of itself, but it's an alternative approach to medication-facilitated airway management for selected situations. I think it has some particular advantages in the pre-hospital setting, particular advantages in hypoxic patients who aren't going to tolerate anything but the quickest interruption in positive pressure ventilation. But clearly I cannot say that this is, has a big evidence base behind it. We have an anecdotal, quite a bit of experience with it, but don't have that evidence base to share with people yet. So I still consider this a controversial topic, but something that is used frequently in our system and doesn't really surprise anybody here. So the other controversy that I just decided to kind of add at the last minute was this idea of skill degradation with intubation as a result of the use of extraglottic devices. And this is, I was looking at my own data recently, and this came to mind. And I also saw this study just recently published from Europe. I think this was in Austria, I believe. A laryngeal tube practice in a metropolitan ambulance service, 5 years, just showing that they went in 2009 from using 2% of patients were managed with extraglottic devices to 27% in 2013, and possibly in 2016, that number has gone up even greater. This is a system that has paramedics and physicians in the field. The paramedics were more likely to be using these than the physicians, but both populations were using these. And so I was kind of curious what this looked like in our system. And this was the easiest data that I could pull, was comparing 2013 and 2015. And just in that period of time, in 2013, 37% of our cardiac arrest population was being managed with intubation, and 2 years later, less than 5% were being managed. And this is in a system that the protocol basically says you absolutely get one attempt at intubation with CPR in progress. and then you move to an extraglottic, but you have the option of using an extraglottic from the outset. And wow, this is incredible what the medics have chosen on their own to do. But this came up because, we were looking on the flip side of in a system of a new RSI program to help manage our non-arrested patients. And the question was, where's our pool of providers that have intubation experience? It used to be cardiac arrest was where you got your experience, and then you could take that and transfer that to other settings. And, in a few years, we're not going to have providers, if they're not in a program doing RSI, for example, going to the ORs and doing things, we're not going to have people that know how to intubate. So we're looking at, how to address that in our system, what we want to do with that. Is this number, are these good numbers? Is this what we want to see for our patients or not? If the studies that come out of ROC, for example, substantiate some of the other studies and say that we should be favoring intubation over extraglottics, then we're going to have a, real learning curve to address going back and getting people up to speed with intubation. If we come to find out that extraglottics are as good, then maybe we want to just continue doing this. And when it comes time to get people up to speed with intubation, we're just going to train them in the OR and other systems to do that. So I thought that was interesting. I'd be curious what other people are finding in their systems as well. So in summary, the topics, controversies we've discussed, we went over a little bit of an update on the devices that are out there and coming. We talked about extraglottic devices. Is this a BLS, ILS, or ALS device? And there's no answer in our system here. We've chosen to make that a BLS device for the reasons provided. I wish that I had better data based on that, but because a lot of this is happening among our volunteer population in very rural areas, I'm embarrassed that our data is just very poor. Do extraglottics provide aspiration protection? They absolutely do. Do they provide as much aspiration protection as an endotracheal tube? They absolutely do not. But is the difference in this population enough to be the deciding factor in what to use? I don't think that it is, but I know that people are going to have very different opinions on that. Do extraglottics affect cerebral perfusion? They do in pigs. I don't think they do in a human population based on the limited information we have, but I can't give you a definitive answer to that either. That remains controversial. Should extraglottics be a primary or secondary airway? That really depends on your take on all of this data and whether or not your providers or you yourself can get somebody managed quickly, first attempt, no interruption of CPR, or if it's not going to be that situation. I think that's going to be a major factor in the decision process. Rapid sequence airway discussed briefly, and then this idea of skill detriment with extraglottic devices as well. And the idea that maybe all of the devices are just helping us to kill patients with positive pressure ventilation. I just want to leave people with that thought as well, and the idea of cardiac arrest management with ventilators, which is, again, a whole separate topic for discussion. So that's my update and discussion of controversies on extraglottic airway use for EMS physicians and other EMS providers. Excellent.
Thank you. Since I'm hosting this, I'm going to take that first question or two, if you don't mind. In our system, when a patient comes in upstate New York, we don't use extraglottic airways too much. When they come in, people aren't familiar with them. And some of the EMS doctors, Derek, myself, Jeremy, we know what they are and we're comfortable with them, but our partners and the trauma surgeons and anesthesiologists upstairs, it causes some fits sometimes. Did you find it took, when you guys started using these devices, that the rest of the hospital system kind of became more familiar and accepted them, or do you still find some folks don't know what they are and give you a hard time for using it in the hospital or in the OR?
Yeah, this was definitely something that was a progression over time and took a lot of interaction and dialogue to get to the point that we're at. And I don't expect that in a lot of systems this could be an overnight kind of change, but it only takes a few people to really drive the process. And as EMS physicians, one of the things that I think is so important for us to do is, if we're encouraging our providers to use these devices, whether we're telling them this is all you have, or we're telling them, hey, make sure that if you get into this situation, you move to this device, whether that be a failed RSI, a certain point in a cardiac arrest, wherever you fall, and that patient comes in with that device into the emergency department. If we yank that device out right away, we have undone all of our training. It's one thing if our colleagues do it and then we can, behind their back, we can throw them under the bus as just ignorant fools and say they didn't know what they were doing. But if we, as EMS physicians and medical directors, if we do that, then we really, it's very hard to convince our providers that this is a good thing for them to be doing. So in our system, when we do change the device out, we almost always have a sidebar conversation with the providers of why. Hey, you know what? This doesn't seem to be working well. We just want to make sure it's not the device. We're going to change it out. Or, hey, you know what? I want my resident to do this instead of the resident upstairs, so we're going to change this out down here. But make sure the providers are kind of included in that conversation. Interestingly, this is anecdote, and I'm trying to get some data on this. But when we have patients come in with these devices, and they're not working well from the perspective of we're not getting great saturation specifically, it is amazing how, and people feel compelled, they troubleshoot, whatever, and they're like, okay, we got to just take this thing out. It's amazing the vast majority of times that we then get the patient intubated, they still have problems with saturation. And I'm not saying it wasn't appropriate to change it out, but it's interesting that it's often inherent physiology and not the device. Mike Steuerwald and I just finished a book chapter for the 5th edition of the Manual of Emergency Airway Management that specifically discusses the management of the in situ extraglottic device. Because I do find when I'm teaching at the difficult airway course for the emergency course, and we do our code airway stations, one of the standard stations I do is a station that has a patient with a king airway in place. And the vast majority of providers that rotate through that scenario have no idea what to do with that device and how to take advantage of it, and if they are going to switch it, how to switch it effectively.
And one other thought, obviously for my paramedic students teaching early intubation for burns and angioedema, don't want to wait until they close their airway and then try to manage it then. So obviously intubation is early is good for those folks. Any use for extraglottics in those patients that you know of? It's just a rare, it doesn't happen very commonly, at least for us.
No, and I mean, certainly there are those patients who, that's back to that kind of RSA contraindication, upper airway obstruction. There are certainly those patients in whom an extraglottic device is clearly not the preferred device. Yeah. But what's interesting is how often I have seen in the emergency department, as much as in the pre-hospital setting, providers that had that patient who got into trouble with the intubation and then never tried to use an extraglottic device as a temporizing measure for a failed airway because they somehow assumed that it wouldn't work because of some upper airway swelling, whereas I think in many of those cases it would have provided an effective temporizing measure for a little bit. So that's the flip side that I have seen.
All right.
But you can use, one thing you can do, and we're doing a lot more of this, is we're doing a lot of endoscopic exchanges of our extraglottic devices in the emergency department with continuous ventilation. And we posted a video on MCRIT showing one of these exchanges with an intern that I was walking through doing this, or I guess a junior resident walking through doing this for the first time ever on a patient. Showing this was a post-cardiac arrest patient who we managed the whole arrest with the extraglottic. Now it was time to change it out. And so that one thing to consider is also on those patients who have the swollen airway and some difficulty, using an extraglottic as a conduit for endoscopic intubation, if you have that technology available, is a lot easier than people think, and it's a pretty slick technique. I'm sure that too many of us are carrying. I've got one of everything in my truck for pre-hospital, response. I don't have an endoscope yet, so I'll have to talk to the A-scope people and see if they want to, give me one.
I can get that fixed. All right. In the interest of time, I'm going to stop on I have a lot more questions, but I'll save it for another time. I will unmute everyone else if they have any other questions. Any from the group? Any other questions for Darren? Oop, I didn't do that. 1 second. Unmute. Oh. Any questions? And Tom's not paying attention. We'll talk to him later.
I'm sorry, I got a student in here.
He's one of my paramedic students, so I'll talk to him later. All right.
Yeah.
Put you all back on mute. Hold on. All right. So I'm going to finish it up and just say thank you to Darren again for a great presentation. This is fascinating, and hope we can have him back again to do some more. I will put out a plug for next month. Mary Mercer from UCSF is going to talk about mass gathering medicine. I have a couple of folks hopefully lined up for July and December. We'll finalize next few weeks. We'll come back next month and we'll do this again. So thanks for joining us, and I appreciate Darren's time for this.
Thanks for having me.